Good afternoon, good evening, everyone. I'm Dr. Keith Crawford, and this evening we're going to be talking about new treatment options for high-risk prostate cancer patients. Now, what I want you to do is we like to give a simple overview of the topic, and then we like to bring in an expert. And our expert for this fireside chat is Dr. Raina McKay. Now, Dr. Raina McKay is a genitourinary medical oncologist, professor at University of California, San Diego, and she specializes in prostate, kidney, bladder, and testicular cancers. But she will be bringing on a little bit later. Now, why this session matters, because we're talking about high risk prostate cancer patients and there are treatments that are available. Yes, the disease can come back, but also we want to help everyone understand BRCA mutations, these BRCA changes. You hear this, they're testing you for it, but what does it really mean? Um, uh, what is the purpose of a trial? Because a trial asks some basic early questions, and we want you to leave with some practical information. Now, this will span about 50 to 55 minutes. And our learning objectives is to understand what BRCA1 and BRCA2 changes mean, learn how PARP inhibitors may work, understand the main question about EvoPAR prostate O2, and know what to ask your care team. Okay? Now, I'm going to share some slides. Okay, so again, we're going to look at BRCA and prostate cancer basics. And I'll go through these fairly quickly because I'm going to tell you what I'm going to tell you. We're going to tell you, and we're going to tell you again. You're going to hear it 3 times. So just relax. I know it may be fast. So the first point is high risk localize. What does that mean? So we know that localized or locally advanced cancers are cancers in the prostate. It has not clearly spread to distant organs or bones, right? And then high risk or very high risk, that category is the cancer has features that may return or spread more likely. The risk is based on several medical factors and not just one alone. And again, we always want you to feel comfortable going back to your care team. And why does this really matter? If I go back just a tad, um, high risk cancers may need stronger treatment plans. Clinical trials may test whether added treatment lowers future risk. The BRCA testing can help guide the decision. Now, some key treatment terms you need to know: radiation therapy, RT, radiation used to kind of kill the cancer; ADT, which is androgen deprivation therapy, and it lowers testosterone; abiraterone plus prednisone. These are hormone blocking medicines. Um, just so you'll hear these names: BRCA1, BRCA2. So first, a lot of people say BRCA, BRCA, BRCA. What does that mean? It's a BR, breast, CA, cancer, one or the second gene. Okay. Now these genes help repair DNA. PARP inhibitors are medicines that block DNA repair proteins. And metastasis is cancer that is spread from the site of origin or where the cancer started. Clinical terms you need to know: randomized. And again, you can ask these questions during the fireside chat, but these are more like the flip of the coin, a computer assigned participants to each treatment group. So there's no bias. Double blinded, where the patient nor the doctor knows who gets the drug or the placebo. And placebo is the same, it looks the same, it may look the same as the active, in this case, sorafenib, um, but it doesn't have that active ingredient. Cohort means group, investigational drug, a treatment being studied, okay, but it's not yet approved. And then metastatic free survival. is how long someone lives without cancer spreading to distant parts of the body. BRCA1, BRCA2, why does it matter? BRCA, BRCA changes can affect cancer risk, cancer behavior, and your treatment choices. BRCA genes help repair DNA. So just remember, I keep on saying this, repair DNA. Okay. A harmful BRCA change may weaken the repair process. And BRCA can guide your precision treatment. So if a cancer has a BRCA change, your team may discuss targeted therapy for or a clinical trial. PARP inhibitors. Think of it at a high level. We got PARP, you got DNA. So cancer cells have DNA damage. The PARP, this protein that we're going to be that you're going to hear about, this protein as well as the inhibitor, repairs damage. But then the protein or the active ingredient in the investigational drug is an inhibitor. So you're inhibiting the repair of the damaged DNA in the cancer cell. And again, first thing I just want you to understand that it's seraparib, or another name for it is AZD 5305. Okay. We won't go into a lot of details because we can ask, but it's a new generation PARP inhibitor. And it's different because it really targets the PARP, PARP1 protein. So you'll be able to ask about that. Now, again, we have an expert who understands it, who's intimately familiar with Evopar. So that's what's going to be exciting about today. You're going to hear it from the person that understands the drug and how it works. So in this clinical trial, it's phase 3. They plan to enroll somewhere around 700 patients. There's 2 cohorts, 2 groups, and then metastatic free survival is the primary endpoint. All right. So just as we're going to focus on what's the big question? And the big question is, does adding seraparib to a standard therapy help men live longer without cancer spreading? The study design, phase 3, randomized, double-blind, placebo-controlled study. And I want to talk about the concept of placebo and standard of care. So we want to make sure everyone understands that. So the study drug, it's 60 milligrams of seraparib, the standard therapy. And no matter what, if you participate in cancer clinical trials, you're going to, at the minimum, get the standard of care. Okay. And I think we can allow, let's bring on our expert, and because we'll be able to dig in a little bit deeper. All right. So let me exit. Stop sharing. And Dr. McKay, welcome. And
It's a pleasure.
thank you for taking the time. Um, it's a pleasure that you're being here. Could and I've come across a lot some of your abstracts that, and so you're gonna have an abstract at ASCO. Um, when we start talking, what would you want a patient to understand? If you were talking to a patient sitting down and you thought that they were a good candidate, so they had, BRCA mutations, what would you first want them to understand about participating in this clinical trial?
Yeah, very good question. So I think maybe we can step back a little bit. And I know you gave a amazing background, Dr. Crawford, on kind of going through, high risk localized disease and the implications for BRCA mutated individuals. So, um, sometimes these terms can be quite scary when people hear high risk
Right,
and all of these items. Really, the risk categorization helps us better tailor and escalate therapy for somebody who's high risk.
right,
So for somebody who's low risk, they may not need as intense therapy. For somebody who's high risk, they need more intensive therapy, but they can still have excellent outcomes with, um, you know, uh, increased likelihood of cure. So for individuals that have BRCA1/2 alterations, and we suspect that of individuals who have high risk localized disease that's potentially curable, with intensified therapy, we suspect that about 1 to 2% of those individuals will have a tumor that has a mutation in the BRCA1 or 2 genes. They may be born with it, and then therefore their tumor has it because they're born with it. Or it may be something that their tumor just kind of picked up along the way. They weren't necessarily born with it.
Mhm.
And people who have, or tumors that are BRCA1/2 mutated in various series compared to tumors that don't have these alterations, we know those tumors are more aggressive. There's an increased likelihood of people progressing through primary treatment and potentially having worsening outcomes. So there's an unmet need in this population of individuals who have BRCA1/2 mutated tumors.
So can I ask you a question?
Uh-huh.
Knowing this, so when you see a patient, are you testing everyone for their genetics?
Yeah, very good question. It is now standard of care that all patients with high risk localized or metastatic disease
Hmm.
undergo hereditary testing. It is the standard and it's in all guidelines, looking for something that somebody was born with to predispose them for the cancer. And it is not necessarily linked with age of onset
Hmm.
or family history. I know
Oh.
sometimes there is an association, but just because somebody has a negative family history or just because somebody is older doesn't mean that they can't be positive. So I've had patients in their 80s where we've discovered that they're BRCA mutated and it's hereditary. So, yes, family history helps inform the decision, and yes, age helps inform.
Right.
But in my practice, I test everybody who's high risk. Okay. And I don't necessarily discriminate by age or family history and say, oh, you don't need the test because you don't have a family history, or oh, you don't need the test because your tumor came on at a later age. I
Mhm.
think everybody warrants testing.
Okay. So a person who is high risk from the standpoint of like the Gleason risk score versus
Yep.
just high risk group people, are they the same? Would you,
Anybody in that high risk bucket, either for Gleason or PSA or stage, if they're in the NCCN high risk group because their disease spread out of the prostate or their Gleason 8, 9, 10, or they've got a PSA greater than 20, any of those variables, they should undergo germline testing. You
okay.
know,
So it's I want everybody to understand. Um, Dr. McKay said NCCN, and so that's the National Comprehensive Cancer Network, and
mm-hmm,
that's what we like to hear.
mm-hmm.
Yes, those are the guidelines that clinicians are using. So NCCN creates those guidelines that clinicians using to give you the best care. So, and that's kind of what we use as our standard. Now, now that you've had this discussion with the patient, can you help us understand? We said earlier that BRCA you had mentioned, makes it tumors more aggressive. And if you are BRCA, so the tumor itself can be BRCA positive, as well you can inherit the BRCA gene.
Correct. That is correct.
So those high risk individuals, you test their blood for the BRCA gene and the tumor?
So in the metastatic setting, yes, we test both. We test the tumor and we test the patient, their normal cells.
Right.
Now, in the localized setting, this trial is looking at a PARP inhibitor for people with BRCA1/2 mutated, whether it's hereditary or somatic. Now, the standard of care is not necessarily to test the tumor. The
Right.
standard of care is to test for hereditary.
Okay.
But this trial does have an embedded screening component that will do the screening on the tumor as just part of the trial that's free of charge. It's done centrally
Right.
to determine somebody's BRCA status. And maybe to step back a little bit, we're a little bit behind the eight ball in prostate cancer. This strategy of taking people who are localized, that have high risk disease, that are BRCA1/2 mutated, has been done in the breast world.
Right.
And
Right.
there's
Okay.
actually already an FDA approval for use of a PARP inhibitor early to prevent recurrence, to increase cure rate in tumors that are breast tumors that are BRCA1/2 mutated. So
Right.
we're kind of like a decade behind in the prostate
A
cancer.
decade? Yeah, a decade? Oh,
Yeah.
that's bad.
So
Okay.
we are now doing the studies in prostate cancer saying, okay, how do we cure more men with known aggressive disease that harbor this specific mutation where we know that that tumor has a vulnerability to a PARP inhibitor? We've already demonstrated that in the metastatic setting, when we treat these tumors with a PARP inhibitor, people live longer. We've already demonstrated that. This study is saying, how can we take these drugs that we know are effective in later line, bring them in to the early disease setting to ultimately actually try to cure more men of this disease?
Right.
That's the goal.
And see, so what you're doing is instead of us being at the edge of the cliff about to fall over in metastatic disease, you're going to get it where you can concentrate a lot of your treatment, a lot of your efforts around the prostate itself, in the prostate itself or
Right.
around the prostate. And then now, here's the question. Why is it the caveat about radiation treatment? So what is that a one-two punch? We're going to radiate to break up the DNA and weaken the DNA, and then we come back with a PARP inhibitor so you can't repair? Is that's kind
Yeah.
of demon?
There is some synergy with radiation, but
Mhm.
if we think about high risk tumors,
Right,
um, you know, not to say the standard of care is radiation, and this is not a surgical trial. This is more of a radiation-based studies, generally for higher risk tumors.
right,
Not to say we're favoring radiation. Certainly somebody can undergo surgery, but when we look at surgery in that context, it's the package of surgery and radiation post-op, because
right,
the likelihood that surgery alone is going to cure a very high risk tumor, when you only look at surgery without the radiation component, it's higher. So this trial actually, it is taking people who have had surgery and have relapsed and are now getting radiation, or people who have never had any treatment for their prostate cancer, that their main modality of treatment is radiation with hormones. So it is actually taking into account people who relapse post surgery, but it's
right.
not a surgical based trial. But there's two groups. There's a group of people who are basically had a recurrence after surgery, or people who are just getting radiation up front.
So, so your prostate doesn't have to be in, but you have to have had radiation.
No,
You have, you
you
can't have.
can't you're so I guess you're right in that you have to have radiation. Right. The time of enrollment, everybody has to have had radiation. You're right. Sorry. Yeah, that
No,
is
no,
right.
no, 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 no. I was just trying to get it clear and because we want everyone to kind of understand. It's like, well, you need to talk with your primary care doctor, but we're going to give you enough basic information so you can understand.
Yeah.
So now let's now this is interesting. We know you've already said in the breast world, PARP inhibitors, right? We know that PARP inhibitors are have now emerged and been FDA approved in prostate, okay, in metastatic disease. But something, what's different about this PARP 1 compared to the other PARP, the older PARPs, or the
Yeah.
first groups of PARPs that came through and were approved?
Yep. The first generation PARP inhibitors targeted PARP 1 and PARP 2. We think that the benefit with regards to DNA repair is largely driven by inhibition of PARP 1. And we think that actually the PARP 2 inhibition component may is more around the side effects of the drug, the low blood counts that people
All right.
get, the anemia and so forth. So by generating a selective PARP 1 that doesn't block PARP 2, which the blocking of PARP 2 is what drives the toxicity,
Right,
we
right.
think we can focus on the therapeutic effect and limit toxicity with a more selective agent.
Hmm. So, I mean, I know it's not a one for one, but when you say toxicities, are we talking about we're anticipating a lower side effect profile or
Correct. That's correct. So we anticipate that with a selective PARP 1, that the bone marrow toxicity that's historically been associated with PARP inhibitors causing anemia or somebody's platelet counts to go down or their blood counts to be affected will be less with a selective PARP 1 as opposed to a non-specific medication.
I see what you're saying. Hmm.
Yep.
So I wanted to ask you a question. Let's go back. And that was a very important point that you made, that a lot of the studies have been done um, in breast cancer. We have some, PARP inhibitor kind of at a general level, but I don't know. There was a study, the Petra study, or was it?
Yes.
How does
That's
that
a,
explain to us about the Petra study and how it helped support this move forward to this particular clinical trial? It wasn't
yeah.
like out of the blue, somebody just prostate, Evo Pro prostate 02. They just named it that. It
No,
a lot of information that it showed positive results. So can you help us
correct. Yes. So a lot of times we need to, before we can test a drug in a large phase 3 setting, especially in a group of patients that are, you know, are receiving curative intent therapy,
Right,
we need to make sure that we have the right dose. We need to make sure that the drug is safe to give. We need to
right,
make sure that there's a signal of activity. And so the initial study looked at doing just that. It looked at in the later line setting, and actually this trial actually enrolled people with hormone resistant disease and hormone sensitive disease, and there was a heterogeneous population of people with metastatic disease that
right.
enrolled. But in essence, it established that the drug is safe. It established the right dose. It established that yes, there's a strong signal of efficacy. And based off of that, that now we've proven that yes, what we hypothesized about this drug is in fact true. We can take that drug and test it in the earlier setting.
Okay. So everybody has to understand that they didn't just pick it, it wasn't a computer randomized, just grab a drug. They've
No,
built everything. Built a strong foundation of positive results about this treatment. So they're not,
correct.
so
There's a hierarchy, right? Like there's like you kind of build your I love the build the foundation, like you said.
right.
And so this trial isn't a first in human trial. There's been hundreds of patients that have been treated with this agent, and now we're testing this specific drug in a specific setting.
So I always like to ask, what's the name of this drug?
Saruparib.
Saruparib. So
Yeah.
Saruparib. Let me say it correctly.
Saruparib.
Saruparib. Remember,
We're
everybody.
not making it easy for people. We're gonna have
Are
like
you sure or not? I can stick with the AZD
yeah.
5305, but okay, Saruparib. So now we know how to
Saruparib.
pronounce it, everyone. So when you go into your doctor's office and you want to have a discussion about Saruparib, you can pronounce it.
There
So
you go.
now,
It's funny. I will say it's funny how also drugs are made, right? Like the ending of Saruparib, the IB kind of ending
Yeah.
is classic for all the PARP inhibitors. There's like, olaparib, talazoparib, niraparib. So all of these IBs at the
Ibs.
end
Okay,
to
so
trigger you that it's a PARP.
remember that, everyone. Just tell them it's like it's that drug with the ib at the end. Okay,
There you
that's how
go.
we can remember that. We just have to give them a little bit of information.
Saruparib, yeah.
So Ruparib and AZD 5305. Yes. Okay. So now let's go. I highlighted. Now, are you going to be talking about this at ASCA?
So, we're not going to be specifically talking about it at ASCO. We've had several trials in progress. The trial is ongoing.
All right.
It's currently accruing patients across the world. It's an international study. And we honestly need the entire community to help ensure we can execute on this trial. We're looking for a needle in a haystack.
Right.
We're looking for the 1 to 2% of individuals that will have a BRCA1/2 mutation. Um, when you think about it, you're like, oh, that's a small number, 1 to 2%. But in actuality, if you say 1 to 2% of, you know, the tens of thousands of people that are diagnosed with prostate cancer worldwide, hundreds of that, like that's actually a substantial number.
Yes.
Prostate cancer is the most common cancer among men, certainly in the US. And, unfortunately, we need to do better. It's the second leading cause of cancer death among men in the US. So even though we say 1 to 2%, we're like, oh, that's such a small number. It actually is a large absolute number of patients,
All
you
right.
know?
But you know what's interesting also about this is that it's just a test.
Mm-hmm.
It's a test that you should just take anyway
Mm-hmm.
if you get diagnosed. So it's not something that's invasive. It's not anything it's in your blood.
Yeah, the germline test is a simple blood test or saliva swab, buccal swab. And then the testing of the tumor is based off of the biopsy that has, that's how you got your diagnosis of prostate cancer. Then we test the tissue.
Mhm. Okay, so we know it's a phase 3. Okay. We know you're looking for a lot of folks. Now, let's move to this cohort or groups, right? Help us understand there's an elephant in the room, and the elephant in the room is called placebo.
Yes, yes. Happy to talk about that.
Let's talk about that and placebo standard of care and how that fits in the two cohorts, the two groups.
Yeah. So happy to talk about that. And as we step back just a moment, I think anybody who has a family member
Mhm.
who's BRCA mutated
Right?
should absolutely get tested. So I think reaching out to that community is important. Like, you said breast cancer or breast related cancer gene, like the moms and sisters of individuals who have this tumor get breast and ovarian cancer, the men get prostate cancer.
Right.
So it's
And
part
see,
of the same family.
what a lot of people don't understand that because it's important if you have prostate cancer and you get tested, you also are generating information for not only your son, but also for your daughter.
Absolutely.
I see a lot of folks,
Absolutely. Yeah. So to answer the question about placebo,
right?
so this trial is looking at testing the addition of saruparib to standard of care.
Right.
Everybody gets treatment and everybody gets the standard of care. That standard of care is hormone therapy with or without a drug called abiraterone or Zytiga that
Mhm.
is utilized in people that have high risk disease undergoing radiation. So
Right.
everybody gets the standard of care. The placebo component comes into the addition of this one drug. Like you said, we're doing a test. We're keeping all the variables the same.
Right.
Everybody's getting treatment. Nobody's getting denied anything.
Okay.
If you didn't enroll in the trial, your likelihood of getting this drug is zero. If you enrolled on the trial, the likelihood of you getting the drug is 50%, but we don't know who's going to get it. But everybody, 100% of people who enroll on the trial will get the standard of care. There is no treatment. So we're
Mhm.
trying to keep the group very homogenous and say, okay, the only variable we're changing is that half the group is going to get saruparib, half isn't. Everybody gets what they otherwise would have gotten.
Oh, so there was. I'm sorry for interrupting. For just to kind of this randomization. And you're using a computer. So it's not necessarily 50-50 when you use randomized, but you'll stop if you ended up with half or the 350 people who are not receiving saruparib, and then you would continue doing the randomization until you had 350 people who would be
Yep.
participating. There's always going to be
Yeah.
350 people or somewhere close to that participating who receive saruparib versus who only receive the placebo, right?
Yeah. Everybody is like this, the trial is about 700 patients, and all 700 patients will be enrolled. Half the patients will get one drug, half the patients will get another drug, or
Okay.
will not get the drug.
We're not getting
And
that.
so it goes just back and forth. And the study is enrolling across the entire world. So there's like a
Okay.
computer algorithm that just says this person goes, they get this person goes, they get that. We don't actually know who gets what.
Okay, I see.
Um, but all 700 are enrolled. And at the end of the day, when the test is done, about half will have gotten the drug, half will not have gotten the drug.
I got you. So, ADT. What
Yeah,
ADT?
very good question. So ADT is androgen deprivation therapy. This is the backbone of treatment for people who have high risk disease that are getting radiation.
Mhm.
So it's for high risk disease, generally the duration of therapy is about 2 years. That's what the standard of care is. The standard of care for high risk localized getting radiation is 2 years of therapy that suppresses testosterone. There's a lot of different forms of ADT. There's injections like Lupron or like Leuprolide, Trelstar. There's also oral formulations, Relagolix, Degarelix. All of those constitute ADT.
Okay.
Um, the other component to this is for some individuals that are high risk, we have demonstrated that adding another drug called abiraterone to
Mhm.
the ADT, and abiraterone also decreases testosterone, just like the other drugs, but works in a slightly different way. We have demonstrated that for some very high risk people, adding abiraterone also improves and delays the time to people developing metastases, and it is FDA approved in some people. So there is a group of people on this study who their doctor may deem them to need this other drug, and that is also accounted for. But it's a decision that's a personal decision made with the doctor and the patient as to whether they are a candidate for the abiraterone.
Well, then let me ask you this quick question then. What happens? So, if you have a high risk localized disease, they started you on abiraterone. You went to the second level, and you're using abiraterone. What happens if you're resistant or you stop controlling the cancer growth with abiraterone? Because we know there's other drugs, even
Mm-hmm.
up to the darolutamide, which is the last of that class. I won't say the
Yeah.
last class, but you know of the four that I'm
Yeah.
talking about, that you haven't been tested on. So how do
Yeah.
you? So if you fail or if you're resistant to abiraterone, would you not qualify for this clinical trial?
Correct. You would not.
Okay.
And I will say this is treating people in the localized setting that don't have metastatic disease.
Hmm.
Um, and the likelihood, and people, you know, they ultimately have about 8 to 9 months to get on study from the time they start their hormones. It's generally around that.
Hmm.
The likelihood of primary resistance to ADT and Zytiga for localized non-metastatic disease in this context, there's nothing that's zero in medicine, but it's really, really low. Um, so it's not to say it's impossible to see it, but I think, you know, um, the rates of that, like being on ADT with a suppressed T on Abby for non-metastatic disease, being treated with a curative intent, the likelihood that somebody's PSA is going to start to rise and on therapy, it's not
Right.
zero, but very low.
Okay. All right. All right. So I'm going to transition off, and we have some questions that we have. There's some folks. Well, basically, the question is about double blind. Could you help us better understand what double blind means?
Yes, yes. Double blind means I don't know as your doctor and you don't know as the patient. So meaning, you know, we get notified of, whatever it is you got when a patient gets randomized, it's a flip of a coin. Do you get
Right.
this or do you get that?
Right.
I don't know what you get and you don't know what you get. So double blind means the doctor is blinded and the patient's blinded. So there are situations, for example, where the doctor knows but the patient doesn't.
Oh, okay. So
So
in this
double means
case,
I don't know and you don't know. We
so
both, two of us don't know.
it takes away the bias. Okay.
Correct. Correct.
Okay. So we have now. Ooh, here's a good question. They e- they're asking about the treatment plan or the timing. How long is this clinical trial?
Yeah, very good question. So the duration of hormone therapy is 2 years,
Hmm.
and the duration of the PARP inhibitor is 2 years, which is the standard of care. Now, the ADT duration being 2 years is the standard of care. Now,
Right, right.
that ADT may have started before somebody enrolled on the trial. So
Hmm.
their 2 year clock may have been already ticking.
Right, right,
So
right.
it's only 2 years of therapy. So in some situations, the ADT may end and the saruparib will continue.
Right,
Actually,
right,
in
right.
most situations, it's likely that the ADT will end and then the saruparib will continue for 2 years because the saruparib only starts when you enroll and get randomized. But
Okay,
the ADT must have started before. Everybody's ADT will have started before.
okay. Hmm. So it's a pill.
Mm-hmm.
Placebo's a pill.
Mm-hmm.
Yeah, 24 months. Um, what can you tell us about side effects?
Yeah, very good question. So I think there's side effects of the hormone therapy, which we'll kind of table a little bit, talk more about side effects of the saruparib.
Right.
So I think the major side effects that are known tend to be related to fatigue. They tend to be related to the bone marrow numbers going down. So
Mhm.
that's something we track very closely.
Right.
We'll check people's blood work regularly when they're on treatment. We'll check some people may have heard the word CBC or complete blood count, where we look at their hemoglobin numbers and their hematocrit and their platelet and their infection fighting cells. We make sure they're not anemic, they're not developing anemia. We make sure their platelets are good and they're not dropping. So if those things happen, there are guidelines and actually rules within the protocol of what you should do.
Okay.
Because this study is being conducted at hundreds of centers across the world, we want to make sure that how people track patients on the trial and how they manage toxicity is very similar. We don't want one doc saying, "Oh, your hemoglobin dropped, just stop the drug," and then another doctor, doing something else. The we want there to be some similarity in how everybody's being handled. Now, of course, there's personalization to this, but I guess what I'm saying is there are guidelines in the protocol to exactly direct what to do if something were to happen. I think the other side effect can be some GI side effects, but those tend to be, pretty minimal. And I will say this, I tell this to all my patients. Sometimes patients, or sometimes there's this feeling like I'm not in control when I'm
Right,
on,
right, right. Mhm.
or I'm like I'm not at, and in actuality, you're in the driver's seat. You're in control as a patient. At any point in time, you can decide to do whatever you want. And you don't even need a reason. Okay. And so empowering people and saying, hey, you're in control.
Mhm.
Yes, there's a protocol. Yes, there are guidelines. But ultimately, the wellness and the benefit of the patient is why we're doing this. And at any point in time, we can adjust and modify things. Um, and I think that that's important to share. Yeah.
So there was one other question, and after this question, I just want to prep you a little bit. If I gave you a minute or 2 minutes
Mm-hmm.
and you wanted to have this elevator pitch,
Mm-hmm.
okay, about the clinical trial and how it's important and it's novel, new, cutting edge, okay, I'm going to give that to you. But someone asked a question about and I think you've answered some of it. How many visits would you have?
Yeah. Um, so it's variable. There's not when somebody's getting their standard of care testing, they're usually coming into the clinic on a clip of about every 6 to 12 weeks, depending on what's happening with them. I think in the context of this trial, I don't recall off the top of my head, so don't hold me to it, but it's about once a month to once every 8 weeks, somewhere in that range of the regularity of the visits. And that's mainly to make sure people are doing okay. It's to check to make sure there's no toxicity, they're feeling well, their blood counts look okay, they're tolerating therapy. Even with the abiraterone, for example, that's a standard of care medicine that requires at least monthly blood work to make sure their potassium levels and liver numbers look okay. So it's not too far off from what somebody would be doing per standard of care. But that's the exact nuances. I don't know that I have the exact number of visits.
Okay. So that was because it kind of dovetails into this next question. So I mean, other than if you're taking injection, but you're taking pills, right? So that means that even you don't have to be very necessarily close to the clinical trial site.
Mm-mm.
If you have the ability to travel, and I don't know if the travel expenses are covered, but in some clinical trials they are, but
Yeah. Hmm.
you could travel to that site because it's not like you need to be monitored every once a week or something like that.
No, no, it aligns with what is the typical monitoring schedule for somebody in this context. So I think this is not a phase one study that requires people coming in and being here for long periods of time, getting blood testing and other things like that. It's a larger study, and the hope is that it's going to be scalable. Like whatever we do in this context will be scalable. Yeah.
So I'm going to do two things. Because we're running close to the top of the hour, and Jerry, I wanted you to put up we'll move it out of the screen, but put up the survey questions. But I want our expert here, Dr. McKay. I want you have 2 minutes, and I'm not saying it's the best thing since sliced bread, but there's this uniqueness about this new therapy. It's not like the old one, older form. It's more targeted. We're moving to more precision medicine, more targeted medicine. And what's nice about this, if you can catch the cancer early, or high risk, than in metastatic disease, the way the other clinical trial was, one would expect that you have better results or a longer progression-free survival.
Yeah.
So I hand the mic to you.
So I guess I will start by saying, how do we cure more men of localized high risk prostate cancer that may be destined to metastasize and impact somebody's survival? We know that 1 to 2% of individuals have a tumor that increases their risk of recurrence. And that tumor has a mutation in BRCA1 or BRCA2.
Okay.
There are drugs that work that have already proven efficacious in the metastatic setting. This study is moving those drugs into the earlier setting so we can cure localized disease.
Okay. Thank you.
Hmm.
I wanted to bring up another point too. BR is breast related
Hmm.
cancer gene, not BR as relates to breast.
Hmm.
So we learned something new today, folks, right?
Hmm.
So another question that someone had while we're waiting to finish this, but we didn't ask about the cost. What costs are covered by the study and what may be billed to insurance?
Yeah, very good question. So generally things that are standard of care, like potentially getting your PSA drawn or getting a scan done, that may be covered under standard of care. Anything that's study specific. And I will say that different jurisdictions, like in Europe, this may be slightly different than the US
Right,
for what constitutes standard of care.
right.
But anything that's study specific, the tissue testing, the drug itself,
Hmm.
many of these elements that are specific to this study where you wouldn't really be undergoing the said procedure or test had it not been for the study are usually covered by the study.
Hmm.
And then the patient reimbursement component is site specific. So there is capacity for patient reimbursement, but different sites have different rules around what they can or cannot cover because this is certainly not a coercion thing, but it's a making sure that people are appropriately, compensated for if they're having to drive in, greater than X miles. And the main reason they're doing that is to be on the trial where they otherwise would have gotten their care close to home. That could potentially be covered, but the site has to permit it to be covered.
Okay. So let's talk about Southern California.
Hmm.
So if you're going to have, if you're in California, if you're anywhere in the world, it's not, are you actively recruiting right now?
We are actively recruiting.
Okay.
So the study is open at our institution. We have a wonderful coordinator, Anna, who's leads kind of the recruitment efforts and getting people enrolled in a seamless kind of way. And we are actively recruiting. I really think we have the opportunity
Hmm.
to really change the natural history of this
Right.
disease. I think this study has uh, is going to have a tremendous impact. But again, we're looking for a needle in a haystack,
Mhm.
right?
But respectfully, a needle in a haystack, we're just looking at about 2% of that population.
Right,
That's
right.
not a needle in a haystack. I mean,
No, no, you're right. That's not because a needle in a haystack is like
haystack is
0.0005%, you
right.
know?
That's right. So let's bring it back because like okay,
Yeah.
it's 2% of the population, but 2 to 4% depending on where you are.
Hmm. Hmm.
And but if you're positive, if you have a BRCA1 and BRCA2, then you need to be looking at this trial if you fall into that category, high risk,
Absolutely.
localized disease. Okay, so I want to say that. Um, Jerry, how are we with time? So we want to got ready? Okay, so we'll do this quickly. And so first thing, let's see, first question. I understand what a PARP inhibitor is and how it may work in cancers with BRCA mutations. 73% said yes, 7% disagreed, and 20% not sure. Now, this is a complicated topic, but
Hmm.
73% agreed that they understood. I understand BRCA mutations are important in prostate cancer, 94%. I understand that EvoPAR Prostate 02 is a phase 3 clinical trial with men with BRCA mutated high risk after radiotherapy and are receiving hormone therapy. 80%. 13% were not sure, but 80% of the people in attendance said yes. I understand that the study medicines saruparib. Right? Okay.
You got it. Saruparib, you got it.
Okay. AZD 5305 is an investigational oral PARP1 inhibitor. 100%. Let's see, I understand the trial compares, oh, here we go. Saruparib with a placebo, and both groups continue standard hormone 100%. I understand that the participants are assigned to a treatment group by chance, and the study is double-blinded, so patients and doctors do not know who receives saruparib or placebo during the study. 93%. I understand that the main goal of the trial is to learn whether saruparib can help patients live longer without cancer spreading. 93%. And I understand what participation may involve, including daily tablets, continued hormone therapy, clinic visits, PSA, blood tests, imaging, and electronic diary. I didn't mention electronic diary, but we know that it's in that patient summary provided. 87% agreed. I understand that the possible risks could include fatigue, nausea, low blood count, and other side effects with hormone therapy. I'm just come through it quickly, but it's 93%. You're doing an excellent job here.
Hmm.
I feel better prepared to talk with my doctor or my care team about BRCA testing, PARP inhibitors, and whether a clinical trial may be the right one for me. 80%. 20% said not sure, but I'll take the 80%. We'll just have to work a little bit harder. 11, do you recommend the session to others? 93% said yes. How do you rate the speaker? 87? Ah, but we'll give you, it's excellent though. So
Thank you.
87% for the speaker. That was you. So, and how do you feel about the session pace? Just right, 80%. Too fast, 13%. Too slow, said 7%. And we are breakdown here. 60% were prostate cancer survivors, 7% were their spouses or caregivers, 7% advocates, medical professionals about 13%, clergy and church leaders, because those are part of our groups that we
Hmm.
kind of disseminate information to, 7%. And there's another group of 7% people that fall in the other category. Dr. Dr. McKay, thank you very
That
much.
was tremendous. Thank you so much.
AstraZeneca.
Honestly, I was going to say, even if you surveyed some medical professionals with those, I think that you'd probably get a similar breakdown. So you all did
Well,
excellent.
okay, well, thank you. Well, you were excellent, excellent professional spokesperson, and it's comfortable because what people now know you, they know who you are,
Hmm.
and they know you're in Southern California, and so people get more comfortable about a clinical trial once they see an investigator who's taking the time to really explain to them this trial and how it
Hmm.
works. And plus, we're going to have this up on video on Fin TV, and we'll send you a copy of that. But we also want to just thank you again, and we'll let you get back to saving those patients. And
Thank you so much, Dr. Crawford.
you have a great, great, great evening, afternoon and evening. Bye.
Thank you all. Bye bye.